workplace important? How workplace environment is very important for menopausal women to remain healthy
Thank you.
and
Thank you.
productive. Thank you so much. For the next lecture, I would like to invite Dr. Jyoti Jaiswal ma'am, the professor and HOD Department of Obs and Gynae, PT JNM Medical College, Raipur. Currently, she is the Secretary General of IMS, Chairperson ISAR CG Chapter, Chairperson IAG CG Chapter, Secretary General SAUCI.
No need to read the CV, Shushma. Only display is sufficient. And I am Dr. Jyoti Jaiswal, your friend. May I start my presentation now? So,
going to speak upon PCOD and its role in
I think
medicine.
chairpersons are changed.
it's all right. I may request to join Sudha Madam and Ragini Madam on the dais, please.
Dr. Sudha Sharma ma'am, current President IMS and immediate past President IMS. Dr.
Uh,
Meenakshi Dev, Senior Gynecologist.
I request the AV system people also then don't start the time before the session starts, number one. And this session is carrying 20 minutes each, not 10 minutes. So please take care of all this.
Dr. Ragini Agrawal ma'am, Secretary General IMS 2025-26.
Shushma? Tell Shushma to join.
I want to request Dr. Shushma ma'am to join the dais. She is immediate past President RMS.
Kavita?
Very good morning, everyone. Hello. Good morning, everyone. So here we have Dr. Jyoti Jaiswal for this talk. So we all know that Dr. Jyoti Jaiswal is Secretary Indian Menopause Society at national level. But 2-3 things I have to tell about her. She is दोस्तों की दोस्त, फ्रेंड्स टू ऑल, ना किसी को अनॉय करती है, ना किसी से अनॉय होती है, सबको जोड़ के चलती है. That's Jyoti. Jyoti, I'm so lucky to have you as my secretary.
Thank you so much, ma'am. And I remember the way you keep everything along with yourself when you are walking ahead. You pull my hand when you are walking ahead. You say to shake my leg together with you. I am very happy and honored to have you as President of Indian Menopause Society. It is my personal gain and it is the gain of Indian Menopause Society as well. We all are learning from you. Thank you so much. So now can I start my talk, ma'am? So PCOS and menopause. What goes differently? A patient of PCOS, actually it is a lifelong endocrine metabolic journey, and menopause does not offer any cure for PCOS. It changes only the phenotype of PCOS. So why this PCOS matters? Because PCOS affects 8 to 13% of women worldwide. It is a large number. The most women with PCOS spend more years postmenopausal than reproductive, because now the age of any lady is more after the menopausal years. The long-term metabolic and cardiovascular consequences persist because of this aging. The diagnostic challenges comes in front of us. Does PCOS exist at menopause? Because the reproductive age criteria are not matching at all. The menses, which is given as the oligo or anovulation as a diagnostic criteria, are no more there. The menses naturally cease, or sometimes at the perimenopause, the menses becomes regular in cases of the PCOS women, which were the sparse earlier. The ovary morphology, which was the polycystic and voluminous, is now get towards the normal size, the volume reduced. The testosterone elevated biochemical evidences may not be in the as compared to as in the control. So the confounding baseline always remain, all women experience insulin resistance. So these findings are not there, but insulin resistance, abdominal adiposity, chronic inflammation, dyslipidemia, and a specific increase in LDL across the menopausal transition remain there and masking the underlying PCOS morphology. PCOS always remain across the lifespan, starts from the childhood, comes to adolescent, gives a different phenotype, then it disturbs us in the reproductive age group for the fertility concerns, then in perimenopause also, it gives lot many problems, and in menopause, people think that PCOS is no more there, but it comes with hyperandrogenism, insulin resistance persists, obesity comes and sets in, the metabolic syndrome become a part of the life. So the phenotype evolves, but the underlying metabolic dysfunction remains same, rather increased than before. PCOS is associated with the insulin resistance, dyslipidemia, cardiovascular disease incidence increase, and the cancer connections. Why this happens? Now the ovaries are not functioning, but what are the different hormonal changes in aging PCOS? The estrogen gets reduced, but androgen do not. It persistently remain there. Increased visceral adiposity comes in, worsening insulin resistance comes in. So menopause amplifies further the cardiometabolic vulnerability. Because the postmenopausal ovary, they are hormonally still active. What remains active? They are responsible for 50% of the circulating testosterone and 30% of androstenedione even after menopause, and the remaining steroid originate from the adrenals and peripheral conversion, adds in the increasing adipose tissue, sex hormone binding globulin decreases, so the free testosterone remains there. That's why the hirsutism remains there. So hirsutism may persist, central obesity worsens, metabolic syndrome prevalence increases, and hyperandrogenemia, which already remain there, that may get persist. PCOS transition into a predominantly metabolic disorder continues. One thing is very common with the PCOS from the early age, that is identification of the insulin resistance. Insulin resistance is the common thread connecting PCOS and menopause also, because this insulin resistance gets continuous and rather increase with the age. So, along with the abdominal obesity, insulin resistance and dyslipidemia, the metabolic syndrome sets in. The long-term follow-up says that metabolic syndrome prevalence in PCOS group is 23% versus 8% in the control group, and the perimenopausal threat is that 43% of the metabolic syndrome prevalence in the perimenopausal women with PCOS and androgen axis carrying a 7% extra relative risk of premature ischemic heart disease. Vascular evidences says that young women exhibit increased carotid intima media thickness. So what is different with PCOS patient and a non-PCOS? In a non-PCOS patient, these risks come later in the life. In a PCOS patient, all these metabolic and cardiovascular risk sets in early in life. So there is threefold increase in metabolic syndrome prevalence compared to BMI matched control. So it is not only BMI, there are few more things also. There is a concept of PCOS and PMOS. What is PMOS? PMOS is polymetabolic ovarian and steroid syndrome. It describes the reproductive and ovarian manifestation, the PCOS, but PMOS emphasizes its broader endocrine and metabolic nature. It requires a multidisciplinary approach, so we should give help to each other. The different systems should come together to treat this as reproductive, metabolic, and psychological health, which is very, very important. Common multifactorial endocrine metabolic disorder affecting women of reproductive life, but it is not only limited to that particular life. It is characterized by the hyperandrogenism, ovulatory dysfunction, polycystic ovarian morphology in the reproductive phase, and later on, as I said, the new pillars sets in, that is insulin resistance, obesity, and increased cardiometabolic risk and diabetes in the later life, which sets in early in the PCOS women. So it is a very vicious cycle of all three: hyperandrogenism, androgen synthesis remains sustained, and insulin resistance increases, go on. So that's why the double risk of burden increases to the society, the double risk of hospitalization, the menopausal metabolic shift is there, and if you will see that 60 to 80% prevalence of insulin resistance increases from 47% to 60 to 80%. There is increased diabetic risk in all the patients who are having insulin resistance. May it be in the younger age, but when they come for the at the age of perimenopause and menopause, these women gets converted with the frank diabetes mellitus type 2. There is high incidence which are not identified maybe in the earlier life and earlier onset compared to the control. So every menopausal woman, the message is that with a history of PCOS deserves a metabolic screening maybe earlier than 40. If the PCOS women is obese, then the problem is much more higher. Because if you will compare, that prevalence is 60 to 80%, as I said, in all women of PCOS, it increases up to the 95% if a PCOS woman is obese. So the glucose intolerance test and early setting in of diabetes is almost mandatory in those patients. Some word about the cardiovascular health. There is endothelial dysfunction because of that vicious cycle and increased coronary artery calcification. Along with the increasing age, hypertension comes in and adverse lipid profile adds on. So cardiovascular risk accumulates across the decades. As the PCOS women ages, a normal women also, I can see, we can see in this chart that a PCOS women is always have a higher incidence of, compared to their age matched people control, they are always having the higher incidence of cardiovascular risk. And this gap remained very high when it is compared in the early life patients. But with the aging, it comes at a common cross point after a late menopause, that other women is also having that much of the chances of having cardiovascular disease as the PCOS patient. Few things about the endometrial health. There is long-standing unopposed estrogen exposure in the reproductive life. So there is increased risk of endometrial hyperplasia and higher endometrial cancer risk also. So any patient with abnormal bleeding in postmenopause or perimenopause should go for a prompt evaluation and never overlook this. Mental health and quality of life is a part and parcel of women with PCOS. Anxiety, depression, sleep disturbances, body image concerns always remains there, and they extend beyond reproductive years also. It's not always that a young woman will have all these things. These things remain with the older women of PCOS also. Bone health has some conflicting evidence that whether it get affected with PCOS or not. So obesity may offer partial protection, but there is no significant difference. Lifestyle factors remains important, and bone health assessment should follow standard menopause recommendation. There is no separate menopausal recommendation for the women with PCOS. Coming to the management part, what should be done for the management? Can we give menopausal hormone therapy? Yes, it's definitely not contraindicated solely due to PCOS. Yes, if there is any specific contraindication present, then we can think of, or we can think of the various routes depending on whether the patient is obese, whether she is lean and thin, whether she is having what kind of VMS she is having. So according to that, we can customize. But Definitely, MHT is not contraindicated, and we should not deny if a patient requires it. Individualization of the risk assessment is important, and it gives benefit for the vasomotor, genitourinary symptoms, and if given in the early window, with the window of opportunity, it gives the long term benefits of the heart health and bone health also. So, what are the practical management tips? The annual metabolic assessment is very important in every woman of PCOS, not only in the reproductive time but in the peri and postmenopausal time. The weight management is crucial. Physical activity is a must. There should be healthy nutrition to be followed all the life. Diabetes and cardiovascular screening is a must, and mental health support. So all these things are important, and prevention is more effective than the treatment, because we know that the lifestyle modification is the first and foremost strongest pillar of the management of PCOS. Future directions for PCOMS is a multidisciplinary concept, a PCOS concept for the management. There is a role of precision medicine. Early intervention strategies always help, and prolonged less disease-free expansion of the life and lifespan care model should be followed. So future lies in integrated endocrine metabolic care, and we all should come together to treat these women as a team. My take-home messages for this lecture will be: the menopause does not end PCOS. Remember, don't care about the PCOS only, don't give care of PCOS only in the reproductive span or in the adolescent. Take PCOS as a lifelong disorder and manage it in menopause as well. Insulin resistance remain a central thing. Cardiometabolic risk increases with age. Vigilant screening is very essential. Lifestyle intervention remains the cornerstone, and MHT can be used when indicated. Women with PCOS require lifelong follow-up and a sympathetic care from all of us. Thank you so much for the patient listening.
Thank you, Dr. Jyoti. It was an excellent presentation with so many carry-home messages, very informative. I just want to add on one thing over here, that this is, it is PCOS is a syndrome wherein it is very difficult to understand it. We have come a long way to understand this, still not understood fully syndrome. Because if we go back to our PG days, it was Steen-Leventhan syndrome. So Steen-Leventhan, they were used to diagnose it by doing, by putting in air into the abdominal cavity, and that they would do the X-ray, and they saw that if the ovaries are 3 times larger than the normal, then came PCOD. The name was polycystic ovarian disease, thinking that it is a disease of the ovaries. Then it was thought that it is not PCOD, it is PCOS, polycystic ovarian syndrome. And now at international level, the name has again changed, because being a managing committee member of the PCOS Society, we all have filled that form. Now it is no more PCOS, it is the polyendocrine metabolic ovarian syndrome. PMOS. The name has changed multiple times. So that's one. There are certain things. PCO does not end as the menopause comes. We all know it. It's not only from adolescence, it starts from the intrauterine life. It runs in families. And now at international level, studies have been done. They say that even the boys are not spared. So the boys also might have, PCOS. Number 3, PCOS women, they attain menopause little later than their counterparts, maybe 2 to 4 years later. 3, they have less vasomotor symptoms as compared to the females who do not have PCOS. They have, because of more hyperandrogenism. So these are the factors, and their libido is also not disturbed. So this all
Because of the
is
testosterone.
because of, hyperandrogenemia. Thank you. It was a lovely presentation.
Thank you, ma'am.
Jyoti, it's a wonderful presentation, and you have came out with the word PMOS in your topic also. As Dr. Sudha has said, that PMOS is going to the word for this, and we are, with your lecture, it is very clear that in menopause, it is not the reproductive issue, we are talking more about the metabolic issue. and specifically the changes of the menopause, which causes the central obesity, insulin resistance. They are more in this group. And the most important thing we have to think, these women can present as a AUB also and the uterine cancer also. So we have to be very, very careful for these women.
As the PMOS is a new concept and a new terminology, but majority of the textbooks currently also accepts the PCOS. So it can be, the both terms can be accepted, but in the coming era, PMOS will be the final term for the no PCOS, rather PMOS. And we should treat it like that. Thank you so much.
For a wonderful lecture, and we should all make our patients aware who are having the PCOS in the reproductive life that they have risk of various metabolic and health related risk, and they should go for annual checkups, and they should maintain their weight and maintain an average physical activity. Thank you very much for very wonderful lecture.
Thank you, ma'am. I want to invite chairpersons for the next session. Dr. Shashi Srivastava ma'am, past president of Bhopal Menopause Society. Dr. Subha Lakshmi ma'am, gynecologist at Suyash Clinic, Bhilai. Dr. Neeta Mishra ma'am, she is senior infertility specialist. Dr. Ragini Mandlik ma'am, gynecologist at Suyash Nursing Home, Nagpur. Dr. Shashmita Swayam ma'am, professor and HOD of Obs Gynae at Medical College, Cuttack. I want to invite Dr. Shalini Jain ma'am for the next talk, Brain Reset, Cognition, Mood and Midlife